Wearing the Indian. Namaste. My name is Varsha Ramakrishnan. I'm from KMC Mangalore and my delegate number is 363. Today I will be speaking to you about a topic that is seen all over India actually, more so in the developing nations, malaria. Now with our study, we would wanted to achieve to find out whether altered hematological parameters could increase our index of suspicion of the malarial parasite. There was a previous study that was conducted whereby they found that in the initial peripheral smear examinations, malarial parasite was not detected in 23% of the cases. In order to re-establish a diagnosis, 21 hours of lab technician time was wasted to recheck all the peripheral smear exams, and it was redone again. What we wanted to find out was if routine investigations like hemoglobin, platelets, leukocyte count, as well as the rest of the normal routine blood parameters could be taken into account, their ranges seen, compared, and try to tabulate whether we could initiate a more prompt diagnosis of malaria on the basis of these changed hematological parameters. Now, malaria, as we all know, is a disease in the tropical as well as subtropical climates. It is caused by the genus Plasmodium, and there are 4 types of malaria: malaria, ovale, falciparum, and vivax. In Karnataka, where we are right now, vivax and falciparum form the subordinates. I'd like to draw your attention to the statistics that we have given here. All over the world, in 000, we have 1,272,000 deaths due to malaria. That is a phenomenal number. In India itself, we have 1.8 million cases, that is cases that are diagnosed every year. This is a sizable problem. Now with our study, what we did was, we took patients with acute febrile illness with absolutely no localizing signs. The number that we took was 606. With these patients, we worked backwards. The blood that was sent for routine examinations, we tabulated all the hematological parameters that I will be speaking to you about subsequently. We took the blood of these patients, we found the malarial parasite, we tested them. After testing all the blood of 606 patients, we found 90 to be MP positive. After this, we redivided it and found out which ones were what parasite, that is vivax, ovale, malariae, and falciparum. We then tried to find a correlation between 3 things. 1, the altered hematological parameter. 2, the species of malaria. And 3, the severity of the malaria and its correlation with the degree of parasitemia. What would be our hypothesis question, you may ask? What we wanted to do was to find out whether altered hematological parameters could increase the index of suspicion. Ours was a cross-sectional study. We ultimately did exactly this. We took the red cell distribution width, the hemoglobin, the total leukocyte count, the platelets, and the red blood cell count as the parameters in question. We worked backwards, we did the peripheral smear examination and the fluorescent tube test and found out whether the patient was MP positive or not. Now we were quite excited with our results actually. What we found was, within the platelet range of less than 1.5 into 10 to the power of 3 per microliter, that is thrombocytopenia, 72.2%, this little green segment that I'm showing you, 72.2% of the patients showed thrombocytopenia. The next parameter we studied was hemoglobin. We found just mild anemia. We had expected from the previous studies that we had done our discussion upon to find severe anemia. But what we thought was altering our findings was that in this case, in this region, leptospirosis is also another clinical finding. So maybe the previous exposure to this disease could have caused a milder form of anemia. Our species-related count that we did, we found that Plasmodium vivax had the largest degree, that is 20% of thrombocytopenia. The next parameter would be the red blood cell count, whereby we found low, that is less than 4.5 into 10 to the power of 4 in 46.67% of the patients. I will now move on to monocyte count. This was reinstated by a study by Sharma and Das, whereby they found monocytosis to be a parameter which we could take into account to find out if malaria could be present in the blood or not. We were pleased to find that in our study, we found monocytosis in 12.73%. But owing to the fact that we had only 90 MP positive per patient, we find that maybe this could have hampered the completeness of this study. In a future study, we might like to increase our numbers of the blood that we study in order to find a better significance of this parameter, which could be very important. The next would be the DLC, whereby we found leukopenia in 24.4% of the people, not as significant as thrombocytopenia. Red cell distribution was increased in more than 63.33% of the people. This parameter in particular, I'd like you to concentrate upon because this is a parameter that not many people study. It is not very expensive to do an RDW, red cell distribution with. And with this parameter, we thought that maybe we could reinstate our suspicion of the malarial parasite. In conclusion, in an appropriate clinical scenario, especially in rural setups, we would like to reiterate that a decreased platelet count, a mild form of anemia, decreased leukocyte count, as well as monocytosis should prompt you to initiate a more diligent search for the malarial parasite. This could save on lab technician time, whereby they would not have to go through all the blood smears that have been given to them, but by correlating backwards to the altered hematological parameters, test for only those blood smears which showed these deferred ranges. As our discussion, what could have been our limitation was the fact that our sample size was not as big as we would have liked it to be. Although 90 is quite a big number, our sample size was collected only over 1 month. We would like to extend our period of study so that we may correlate with the degree of parasitemia and whether we could correlate these
Good evening, everyone.
and how severe